Welcome back to my channel. Still on acid-base balance. Today the focus will be on anion gap, and that will form part 4 of 7. The anion gap. In chemistry, we have both the cations, that is the positively charged, and anions, the negatively charged ions. The anion gap is the difference between some measured cations and the measured anions. And you can make use of serum, plasma, urine for this analysis, but mostly we use the serum. In metabolic acidosis, the pH will be low, bicarbonate level will be low, and PCO2 should be between the normal range or slightly low while trying to compensate. Then we should determine, are we dealing with high anion gap or low anion gap or normal anion gap metabolic acidosis. In that case, we will go into some small level of mathematical expression. The normal range of anion gap is variable depending on the laboratory and the individual. Some will go for 4 to 12 millimoles per liter as the normal range, that is without putting the potassium into consideration. And others will use 8 to 16 milliequivalent per liter. We will, however, be looking for high range of 10 to 20 milliequivalent per liter if potassium is added. And commonly, we use the expression without potassium. So, sodium minus addition of both chloride and bicarbonate ions will form the mathematical expression. Based on the values that we might get, we could be dealing with high anion gap metabolic acidosis, normal anion gap metabolic acidosis, or low anion gap metabolic acidosis. In the case of high anion gap metabolic acidosis, it means after the mathematical expression, the result is greater than 12 millimoles per liter, because I will stick to the normal range of 4 to 12 millimoles per liter as the normal range. So anything greater than that is high anion gap metabolic acidosis. And then we should be looking out for DKA, diabetic ketoacidosis, lactic acidosis, loss of bicarbonate ion, or renal failure. You can just have this mnemonic down as CAD-MOD PESR as carbon monoxide, aminoglycoside, theophylline, methanol, uremia, DKA, paracetamol, ion, lactic acidosis, ethanol, salicylate, and renal failure. In the case of normal anion gap metabolic acidosis, that will be indicative of bicarbonate ion drop. Okay, so when HCO3 minus has dropped, then what will happen? Chloride will rise because the chloride ion must replace the negative ions that have been lost. Hence, we'll be dealing with hyperchloremic acidosis. And with that, you can have fused decast in addition to all that we can pick here. And that will be fistula, ureteroenterostomy, saline intravenous fluid, endocrine as hyperparathyroidism, diarrhea, carbonic anhydrase inhibitor like acetosulamine, ammonium chloride, renal tubular acidosis, or spironolactone. In the case of low anion gap metabolic acidosis, that is pretty rare. Most of the time, low anion gap metabolic acidosis will be secondary to laboratory error, but is very common in the face of hypoalbuminemia, and that will lead to the retention of chloride and bicarbonate ions. Remember that very calculation, okay? When you have sodium and then you take away the sum of the chloride ion and bicarbonate ion, then you will get your value of the anion gap. So this is likely going to occur in cancer, burns, kidney disease, infectious conditions, hypothyroidism, or liver cirrhosis. It's also common in both monoclonal or polyclonal gammopathy like IgG paraproteinemia of multiple myeloma, in bromide-containing medications, and lithium. With that, I come to the end of anion gap metabolic acidosis as far as acid-base disorder is concerned. This is part 4 of 7. We'll still have more to talk about. Thanks for listening. Remember to share. Remember to subscribe so that I can get all my presentations immediately they are published. I appreciate it.